task?
Yeah.
Okay, started.
Next slide, ma'am.
After that, I will have questions. Okay.
Hmm. The slide, oh, yes.
Started your 10 minutes time.
Hello, I have read this. I'm the examination candidate. I have read the instructions and I'm ready for the structured discussion.
Okay. So
And
what
Amrita.
initial, yeah, what initial steps will you take after patient has been anesthetized in preparation for the surgery, planning a vaginal route of hysterectomy?
I'll ensure that the WHO's safety checklist was followed and pre-anesthetic medications like anti-emetic, antacids, antibiotics were given. Then position of the patient, which is ideal is lithotomy position, and patient should be propped up properly with pads behind the knees, taking to avoid any injury to the lateral perineal nerves. And after that, a metal catheter needs to be inserted to empty the bladder as well as to know the um, edge of the bladder. Uh, After that, bimanual examination will be done to know the size, position, and mobility of the uterus, and also to know any adnexal pathology.
Okay. What you will be looking for when you will be doing a bimanual examination?
Yeah, I'll see, apart from the cervix and uterine pathology, I would like to know the descent of the uterus, whether there is any other prolapse like anterior or posterior, cystocele or erythrocele, rectocele or introcele, and the degree of descent of the uterus or and cervix.
Okay. Now undertake vaginal hysterectomy in this case using appropriate instruments at an appropriate time. Okay.
Um, so once the Here
The
I can
patient
see
is under
the
anesthesia in lithotomy position, painted, draped, catheterized. Now, how you are going to proceed?
a sim speculum needs to be inserted. Either a sim speculum or Award's self-retaining retractor can be inserted with the help of two uh, valsellum. Anterior and posterior lips of the cervix can be held and pulled down to know the descent. And vaginal epithelium can be infiltrated with 10 ml of lidocaine along with adrenaline with 1 in 10,000 dilutions to avoid excessive bleeding as well as to delineate the planes. 2 to 3 centimeters of from the cervical os, it needs to be infiltrated. Then a circumferential incision can be made by either by a diathermy or knife, and the vaginal epithelium along with the cervico-vaginal fascia to be dissected either by blunt dissection or using a knife, scissors, scissors by Mayo scissors or McIndoe scissors, taking care, keeping the tip of the scissors not to point upwards to avoid any injury. Then once the vaginal epithelium is reflected, then the cervix is lifted up to access the posterior vaginal epithelium, and the posterior vaginal epithelium is reflected and dissected in the midline to access the pouch of Douglas by cutting the peritoneum, taking care not to injure any internal organs. Once the peritoneum is open, that is pouch of Douglas is open, the uterus the ligaments can be accessed by McIndoe's, that is cardinal ligaments, by passing a finger laterally, taking care to clamp the McIndoe's ligament close to the uterus, and clamping, cutting, and ligating the ligament laterally, and suture ends will be kept long to further to clamp the for further later access. Then either the McIndoe's can the similar opposite side McIndoe's will be clamped, cut, and ligated. Similarly, uterosacrals can be done along with this or in separate steps can be done. Once the ligaments have been cut, clamped, ligated, the second uterine artery will be carefully clamped along with the anterior and posterior peritoneal folds to avoid any hemorrhage, and with right angle clamp. This will be double ligated without any transfixation. Once the uterines are done, then the anterior vesico-uterine pouch needs to be accessed by taking a finger behind the uterus, and the uterovesical pouch can be accessed. The uterovesical fold can be held with the tooth forceps and can be opened by scissors, Mayo scissors, between the two arteries. small arteries. Then once it is accessed, the bladder to be pushed up and taking care to avoid the ureters as well. Um, and the uterus, tubo-ovarian ligaments will be accessed, clamped, cut, and ligated. This will give if the ovaries are to be retained, tubo-ovarian ligament will be clamped. If it is the ovaries also to be removed, it will be inferior ligament to be clamped. Once the tubopelvic ligaments are clamped, tubo-ovarian ligaments are clamped, the uterus can be delivered out, and all the pedicles will be brought to the vault, and the vault will be sutured in 2 layers, interlocking or interrupted sutures, continuous interlocking or interrupted sutures, and the lateral Meckenrod ligaments along with uterosacral ligaments will be incorporated into the vault to avoid any post hysterectomy vaginal vault prolapse. The peritoneum will be sutured, and the vault can be left open without
Okay. Do you want to add
and
anything?
yeah. So if there is any descent, excessive descent, like cervix to the vulval outlet, this prevention of like Meckendos-Culdoplasty or sacrospinous fixation can be done. McCall's Culdoplasty will be done to prevent prolapse after the hysterectomy. Then the patient, after the surgery, the specimen will be sent by correct labeling, and the patient will be monitored post-operatively by giving IV fluids, antibiotics, and pain relief. The patient will be informed about the details of the surgery after postoperatively, and she will be in all the procedure will be documented, and the patient will be informed of the any red flag signs before discharge, about when to return if there is any bleeding or a fever or any abnormal discharge with foul smell. uh,
Done?
yeah, yes, ma'am.
Okay. Anything else you wanted to add? Okay. Anybody would like to comment on her performance? Please, audience, participate, be active. Don't be a listener.
Very bad.
Ma'am, ma'am, yeah, she did very well, ma'am.
Ma'am.
And
uh,
dissection will be done first, ma'am, so that when
Uterine vessels. Yeah,
we
uterine
put the
vessels.
bladder up, it
Then
prevents the
also
bleed.
ureter. Yeah. Yes, one important step. So, compromising patient safety. Yes, second person who would like to, who wanted to comment?
Madam, actually, I just wanted to add something here that after opening the uterovesical fold, it is better to clamp the uterine vessels. And
Yeah, she has
also
mentioned the
that,
same thing. She has
yeah,
mentioned.
because Yeah, yeah, because
Chances of
this is for two reasons. Ureteric
ureteric
injury,
injury.
as well as it is better that we clamp, because to avoid any obvious vessel injury or anything that we might
I
miss.
think
And
she might have forgotten that she has not opened a pouch, because when she was taking uterine vessel, she said that we need to incorporate anterior and posterior fold up you peritoneum. She
yes,
might
ma'am.
have missed out. Okay, so steps of hysterectomy or steps of any vaginal means this surgical procedure, it needs to be thorough in your mind. For that, you need to practice these steps thoroughly day and night. So your steps should not go wrong at any point. Any wrong step, the whole patient safety gets compromised and you will not pass the station. If you will ask me, core surgical module and that two steps of hysterectomy or steps of abdominal vaginal hysterectomy, I think these are the easiest things to crack. Because if you are aware about the steps, if you are doing it in and out, you will not miss out on any wrong thing, and they will I accept a minor deviation. Okay, they will, I will be discussing that also. They will accept minor deviation because everywhere, uh, uh, person to person, some techniques are differed, but the basic techniques will not never ever it will differ. That means opening a pouch, opening p pouch, uterosacral, uterine, and then cornual. Okay, so these techniques are not going to differ. Doubly ligated, two clamps, checking hemostasis. These techniques never ever going to get out. So these are the easiest tasks to score more and more when it comes to MRCOG. That is my way of having this kind of task. Okay, at presenting, if you are thorough with your steps, nobody is going to cut out your mark. Because Dr. Amrita, I have scored good on your first question. uh, I have passed you on first question, I have passed you on second question, I have passed you on fourth question, that was my post operative care. But the main crux of this station is this vaginal hysterectomy steps. I have failed you, and this is the most important thing. Okay, most important gist of the task. So if you will not explain the steps in a clear manner, there is means that less likely you will clear the exam. Any steps going wrong will not give you a clear pass. So remember this. Here I'm just little bit strict with all of you, but it is just to make you aware how the RCOG thinks. Okay. Anybody wants to comment? Then we can go through the answer key.
Madam, also, I just wanted to clarify one thing. Just a doubt that McCall's caldoplasty is to prevent an enteroseal in the future, right?
Yeah. Yeah.
Yeah. And vault fixation, I mean, vault suspension is different from McCall's caldoplasty, right?
Same way, with its same thing also. Means it involves what is caldoplasty. It takes both the uterosacral
Uterosacral, yes,
along
and
with
the vaginal mucosa and the peritoneum.
posterior peritoneum, and it it involves the both the uterosacral and vaginal vault. So basically, both the
Ex-
things can be taken care.
Okay,
Excess
okay.
peritoneum will be obliterated, ma'am. Pouch
Yeah.
Yes, yes,
obstruction.
yes,
Yes. So
absolutely.
that
And
enterosil
this
will be
uterus,
prevented.
yeah.
Prevention of enterosil, and since it will be uterosacral suspension, that wall prolapse will be also minimized.
Okay, thank you, madam.
Okay. So Amrita doctor, you have to
Yeah,
practice. This is one
I
of the
didn't practice.
easier tasks. Yeah. So it seems that you are out of practice. Anybody would like to comment? That is what I had mentioned here also. There are few more points which I had mentioned. Okay. One point
Ma'am,
is why you will like to incorporate anterior and posterior fold of peritoneum while taking uterine. Any particular reason?
to avoid any bleeding, ma'am.
No.
The further branches of,
Retraction of the vessels.
Retraction of vessel can happen, yeah, that is
Yeah.
what.
yeah.
If you will not involve both the folds of peritoneum, then the vessels might get retracted. So to include adequately uterine and its small branches, you are going to doubly clamp. Okay. You are going to doubly clamp here. one thing. Then what you have not mentioned, traction, counter traction was never used by you. Very important in vaginal hysterectomy. Traction, counter traction plays a very important role. Okay. Next thing is opening of A pouch, opening of P pouch was not very clear. You just randomly opened it. I didn't get it actually. Yes, everybody pointed out that uterine was taken prior to opening up the AV fold. One thing, retraction. Nobody pointed out that she didn't retract bladder when she started opening her A pouch. Never she retract the bladder. Yes or no?
Yes, ma'am. And also ureter will be moved away. I think
Yeah,
the
yeah. When
ureter
you
was
will be
not
opening,
touched.
yeah. Even not before opening up the A pouch, we start retracting the bladder.
Retract the bladder, yeah.
Yes, so that is another safety thing. Sleepage I mentioned. Then I mentioned.
Cervicovesical fascia and vaginal mucosa reflecting that will reflect the bladder up, no, ma'am. But I didn't tell
No,
the
no, no.
retractor should be held to
Yeah, you
retract the
see,
bladder.
whenever somebody is
Yeah,
doing a vaginal hysterectomy, your assistant will always retract anteriorly bladder and posteriorly
yeah,
rectum. When you
yeah.
introduce a what speculum, you have not mentioned that also. Okay. So
Sim
these are the few
speculum.
sim
No,
speculum.
Sim,
she mentioned.
After opening the P pouch, you have to introduce either sim speculum or
Landens.
what Landens is for
Landens.
bladder. Landens is for bladder. What
Yeah.
speculum or sim speculum after opening the A pouch, P pouch. Okay.
Yes.
This is what the most of the steps went wrong. Okay. So now coming to the answer key. In short, very nicely you started with the first question. It is a case of endometrial hyperplasia with failed medical management of AUB posted for vaginal hysterectomy. I would like to ensure the first question's answer is because the patient has been consented. If the patient is on table, that means ensure the patient consented and WHO safety checklist will be fulfilled with team briefing. Patient will be in lithotomy position under all aseptic precaution. Venting and draping will be done. Catheterization or emptying of bladder, you mentioned a metal catheter. Either it can be a simple metal catheter, red rubber catheter, or Foley catheter. It depends upon the type of catheterization you want. Per abdominal, per speculum, for vaginal or bimanual examination will be done under anesthesia to confirm the findings, specifically any abdominal masses, descent, you mentioned, mobility of uterus, in size of the uterus, any other prolapse, whether there is any associated enterocele, enterocele, posterior vaginal wall prolapse or anterior vaginal wall prolapse. Fornicial pathology or adnexal pathology. Ensure here I am going to instruct the scrub nurse to keep the trolley of vaginal hysterectomy ready because our communication with colleague domain is also getting tested in this case. What will you looking for when you will be examining the patients? Yes, per abdominally any mass, bladder palpable, cervix, check the cervix, vaginal health, descent, any additional bulge or prolapse visible, that is cystocele, rectocele or enterocele. On per vaginal examination, it will be size, position, fixity or mobility, and adnexal pathology. Okay, so these are the descent also on per vaginal examination. Then describe the various steps you will be taking in performing a vaginal hysterectomy in this patient. Identify the instruments while performing though. So whenever you this task will come to you in the exam, please hold that specimen in a proper way. How you are going to hold in your exam. Okay, what we learn in our clinical exam means when we are passing our clinical exam during our MD MS core degrees, we used to hold that instrument in a proper anatomical position, its own position, so you have to hold those instruments appropriately. Now the first step is you mentioned here regarding the grasping. Introducing sim speculum, you mentioned. Yes, one can introduce sim speculum first, then one needs to grasp anterior and posterior lips of cervix by valsellum. Adequate traction needs to be given so that your uterosacral will be stretched out and the descent additional, it will give you additional descent. Infiltration can use local anesthetist, either bupivacaine or lignocaine. Paracervical means it depends upon the person, people. There are two ways. There are few people who prefer infiltration. There are few people who do not prefer infiltration, they go directly. So whatever techniques you can explain both the techniques in bupivacaine or in local anesthetic technique. The advantage is there will be delineation, less bleeding, and pain post operatively, but the con will be vasoconstriction, which will mask the bleeding which might present post surgical. So this is a cons. So either plus minus lignocaine or local anesthetist you can use, or you can the person who will be means performing the way whatever way they want. But this is the exam, we will be going ahead with the standard procedure, standard techniques. A pouch opening. Now the A pouch opening, a circumferential incision with the help of blade number 10 on the anterior vaginal portia vaginalis. You have to identify the bladder sulci. The first thing, identify the bladder sulci or rugae, and below that you are going to take a circumferential incision with the help of blade number 10. Again, you have to apply traction on the cervix and separate the bladder with the help of either sharp or blunt dissection. Use Landon to retract bladder here. Okay, so Landon bladder retractor to you retract your bladder. Once you, if you are in a right plane, you will identify the shining fold of utrovesical fold of peritoneum. Open this peritoneum by a sharp cut with the help of two straight artery or two curved artery. In between that, you can cut this. Then there might be a vesical peritoneal fluid which will be coming up. Here you can confirm with the help of introducing your finger and trying to palpate the uterine fundus. Or if you think you are in a wrong plane, you can palpate the bulb of the Foley's also if you have catheterized the patient. So this, no need to explain this, but this is just for a practical reason. So once identified a fold of peritoneum, give a sharp cut in between two artery forceps, and you introduce your Landon retractor anteriorly and keep the bladder away from your surgical field. Now, so when this technique, okay, so this means opening when anterior access is not feasible, the uterocervical ligament can have been after clamping of the uterosacral ligament, one can go from a posterior approach also after opening a P pouch if you are finding it difficulty. But while clamping a uterosacral ligament without opening A pouch, still there is a high chances that ureter might get injured. Now P pouch, how you are going to open this P pouch? Identify the uterosacral junction where you are going to apply two Ellis forceps and palpate in between two Ellis forceps that there will not be any bowel or any thick mass, and give a bolt cut. Give a bolt cut and see the window of peritoneum. Widen that window and introduce your sim speculum to keep rectum away. If you think you are in a right plane, extend the incision and introduce your awards self-retaining speculum posteriorly, which will again keep your rectum away from your operative field. Okay, so P pouch hold posteriorly vaginal wall by two Alice forceps at uterosacral junction. Palpate for any abnormality in the pouch of Douglas, especially any pathology, loops of bowel. Retract posterior vaginal wall. Retracting posterior vaginal wall is very important with the help of sim speculum to keep away from to keep rectum and bowel loops away. Sharp incision over posterior wall in between two Ellis under traction, and C for small window of abdominal cavity. Enlarge and introduce award self-retaining speculum posteriorly. So this is actually your Zeppelin clamp, and this is a straight artery forceps. So now once the uterosacral ligaments are accessible or visible, you can use the Zeppelin clamp. How you are going to apply this clamp is also important. It will be always perpendicular to the uterine axis. The key point here is to apply the posterior blade of the clamp by feel and ensure correct position. It will be perpendicular to the ligament prior to clamping. Cut the pedicle and ligate using a transfixing suture to avoid slippage at this stitch. Why transfixation? It will give you, it will not sleep. It will not sleep. Okay, keep the thread long so that you will identify and put it onto the, apply onto the straight artery forceps, so that at the end of the surgery, at least you will identify which will be your uterosacral and which will be your cornual structures. Repeat the procedure on the other side. Second pedicle will be uterine vessels. It will be always double clamped. Uh, Now here you are going to incorporate anterior and posterior fold of peritoneum with adequate contralateral downward traction on the cervix, which will make your vessel more accessible. Okay. Cut, ligate. It is not going to be transfixed here, not to transfix. So not transfixing this vessel because there is a chances of injuring any blood vessel and causing hematoma. So you are not going to transfix. This is again a patient safety point. Confirm hemostasis at this pedicle because this pedicle is at risk of bleeding. Doubly ligate, doubly clamped. Okay, doubly clamped, doubly ligated. Check hemostasis. This should be at all uterine vascular pedicle. Check the raw area in between those two pedicle because many a times that raw area bleeds. Now your third clamp will be the tubo-ovarian pedicle. Deliver uterus out. Unless and until you will not deliver your uterus out, you will not be able to apply this tubo-ovarian pedicle. Okay. Palpate whether there are any adnexal pathology. Apply clamp ensuring no bowel or omental loops will be involved in the clamp. Cut pedicle which can be secured. Double ligate. Ensure complete hemostasis here again. If the uterus is enlarged, so one might not be reaching the third pedicle, the last pedicle in third clamp. You might need to take few more extra clamps. Okay. Confirm hemostasis at all pedicle. Then send uterus for HPR after labeling. McCall stitch is taken at this point after confirming hemostasis at all the pedicles. It should include uterosacral ligament on both side and posterior peritoneum and vaginal mucosa in the middle to reduce walled prolapse. Here we can use the Spencer holes wells to hold the fold up peritoneum to get incorporated in McCall's stitch. At the end of the uterosacral suture, with the needle is taken through the vagina and plicated with its contralateral counterpart. The free ends are tied intraperitoneally. Okay, so both the ends are tied intraperitoneally, and then the vault will be closed either transverse manner or vertical manner with the help of 10. It is not 10. Okay, it is 10 vicryl or polyglacting in continuously locking manner. Swab instrument count and needle count will be taken. Vaginal packing is very important. It minimizes the vaginal oozing. Catheterization, VT risk assessment, catheterize and vaginal pack is important. Ship patient to post-operative monitoring on NUAS chart. Then post-operative instructions, yes, complete operative note, document her care plan, monitor her on news charts with analgesics, IV fluid, VT assessment, encourage early mobilization. Once started orals, past motion and urine, patient can be discharged to primary care with instructions of bleeding, red flags, when to report, avoid sex and tampon and douching. Remove of pack following day and document it. Removal of catheter. Inform when to contact GP or when to come back. 24-hour contact details. PIL of recovering after post hysterectomy. So these are the questions what I had in this task. Information gathering, understanding of essential pre-operative investigation and relevant clinical assessment, ability to interpret clinical finding, investigation when making decision about surgical technique and approach, ability to describe clear action plan, ongoing management plan and surgical procedure, interpretation of the details provided. Communication with colleague, able to communicate when we are discussing with the colleague or answering, that is again a communication. When and whom to call whenever there will be complication, always able to recognize one's own ability, limitation, call for help and refer other specialty. S-bar tool whenever possible. Sequential demonstration of knowledge of steps of vaginal hysterectomy, scrub nurse and senior. Patient safety, understand the principles of safe surgery. That means each and every step matters a lot, including WHO safety checklist. Understand moving, preparing and positioning in unconscious patient for vaginal hysterectomy. Very nicely you had mentioned that knee support and it should be given to the patient to prevent injury. Okay, the nerve injury. Like recognition of limitation of abilities and demonstrate and understanding when to call for help, involve senior colleague and other discipline, knows the principles of safe surgery, including use of prophylactic antibiotics, bladder catheterization, and vaginal pack. Drug allergy is excluded for safe prescription. Crucial steps to avoid injury to nearby structure like bladder, bowel, ureter vessels. So while doing so, that traction, counter traction, retraction of bladder, retraction of rectum. Whenever you are taking uterine vessels, how you are going to take uterine vessels plays a very important role, not to miss out. Applied clinical knowledge, appropriate knowledge in relation to the gynecological surgery, including technique, the risk and benefits of various procedure, ability to critically appraise medical literature in relation to the surgical procedure. Okay. Any question? No. Okay.